In this section, we are going to talk about several different pain theories in order to help us organize these concepts so we can apply them to clinical practice. So, the biggest thing we need to be aware of is that there is no center of control for pain in the brain, meaning when someone is in a painful state, all of these areas in the brain get lit up on a functional MRI. So, everything from the limbic system, which houses our emotion and behavior and long term memory, our autonomic nervous system, our voluntary movement, our memory, bodily functions, cardiac functions, respiratory functions, our consciousness, all of these things get stimulated when someone is in a pain pattern. That is what makes pain so complicated. It's not one specific center of the brain or spinal cord that's getting stimulated, it's all of these things. So, any intervention we do has to address the multifactorial approach of why people are in pain, which could be for a number of reasons because all of these different things get stimulated when someone's in pain. Let's look at some of these pain theories. So Melzack and Wall are known for their groundbreaking work in pain theory establishment in 1965. The gate control theory of pain is really what we rely on from an intervention standpoint in our healthcare system. So many of the modalities or manual therapies that we use rely on the gate theory dating back to 1965. So, what the gate control theory of pain really states is that when we have a painful stimulus, we get a C fiber stimulation, a nociceptive stimulation, we get that information going to the brain, and it's a pretty strong signal. However, when we then stimulate an A beta fiber by also touching the area, it stimulates an inhibitory interneuron, which is then going to dampen or weaken the signal going to the brain. So the perception of pain by the brain is actually less because we've also stimulated A beta fibers. So think, for example, if you slam your finger in the door, the first thing you do is grab a hold of it, you put it in your mouth, you touch it, you put it in between your legs. You're just grabbing a hold of the area that's painful. And that's because you're trying to stimulate these A beta fibers, which will then stimulate the inhibitory interneuron and truly dampen the signal of pain that's going to your brain. Again, so many of our interventions that we do from a therapeutic intervention standpoint really rely on the gate control theory of pain from 1965. So, huge groundbreaking information and still holds true to this day, but it certainly doesn't give us the entire picture. Another pain theory is the conditioned pain modulation theory. And what conditioned pain modulation theory basically states is that pain inhibits pain. So when I was growing up, I have an older brother, and of course, older brothers torture their little sisters. And so I remember falling and hurting myself and grabbing hold of my arm and crying. And he'd come over and he'd punch me in the arm. And I'd say, "What was that for?" And he'd say, "Oh, well, your elbow feels better now, doesn't it?" And he thought it was so funny, and I would just cry more. But as I am older now and sort of learning about the conditioned pain modulation theory, that's exactly what he was exhibiting. If we apply a painful stimulus near another painful stimulus, then the original painful stimulus is dampened. So basically, pain inhibits pain. And so this gives credence to information on why maybe things like dry needling might work in and around the area. Or it gives us a reason to not necessarily have to be doing a specific intervention right on the location of pain. Simply being near the location of pain can sometimes be just as helpful. Melzack, again, came back in 1996 and started talking about the neuromatrix of pain. And really, what he talks about with this theory is that pain is produced in the brain and spinal cord and not necessarily in the peripheral tissue. Now, what he does acknowledge is that this doesn't negate the other pain theories that are out there. Certainly, we have, if we put our hand in a fire or put our hand in a painful stimulus, we are going to get a signal to the brain that tells our body to remove our hand from the painful stimulus. So certainly he's not negating the peripheral nervous system in this theory. He's just stating that it doesn't give us the entire picture. Sometimes the brain and spinal cord, in and of themselves, and despite nociceptive stimulation or not, can create pain sensations. So really what he does is he starts talking about shifting the pain perception from the peripheral nervous system to the central nervous system, but he doesn't negate the peripheral nervous system involvement. Of course that there is peripheral nervous system involvement for sure, but he puts more of an emphasis on the central systems of the brain and the spinal cord here. This explains things that are painful when there is no nociceptive stimulation. So things such as nonspecific low back pain, when there is no mechanical stimulus to be giving people low back pain, or phantom limb pain, or things like fibromyalgia, when we're unable to identify a specific nociceptive stimulation, but people remain in pain. Why is that? And the neuromatrix theory of pain discusses this concept, that it has more to do with the central nervous system than any type of peripheral stimulation. So again, pain and nociception don't go hand in hand. If we stimulate a peripheral nerve and it gives us a painful sensation, certainly we are going to be in pain. However, peripheral nociceptive stimulation does not need to occur for people to be in a pain pattern or be experiencing pain. So pain and nociception don't go hand in hand. Nociception is simply the peripheral nervous system stimulation, whereas pain is truly a symptom. They don't go hand in hand. Pain is extremely conscious, it's subjective, it's peripheral, it's central, it's emotional, it's situational based on the task and based on the organism. It's cultural and it's extremely personal based on our past experiences. No one is going to have the same exact pain experience compared to the person next to them. And as healthcare professionals, we need to really be prepared to deal with pain in an extremely individual way. If we try to take one pain management solution and apply it across the board, we are going to be unsuccessful in pain management for our patients. So pain is all about meaning. When you say something to somebody, it could have two different meanings, just like the pain sensation is going to have two different meanings. So Lorimer Moseley does a great job of going through the pain sciences. I think if you haven't checked out his DVDs, I think that he's got a great DVD aptly entitled Pain. And he takes some really difficult concepts and boils them down into some really simplistic explanations. So I would highly recommend looking at his information as well. And so pain really is about meaning. So he talks about this in his DVD as well, but think about all of your past experiences, and same thing for me, I'll think about my past experiences. If we're walking down the street barefoot and we both step in glass and we cut our foot, to you, you may not think that that's a big deal, right? You pull the glass out of your foot and you move forward. But for me, maybe I go on freak mode. I want to wash it out with soap and water. I want to put a Band-Aid on it. I am just a mess because I've cut my foot with glass. Well, because maybe I had an experience years ago that landed me in the hospital and I had to get IV antibiotics because I stepped in glass or I cut the bottom of my foot in some way, shape, or form. But you didn't have that experience, so you don't freak out at that nociceptive stimulation. The exact same nociceptive stimulation of cutting our foot can have two completely different expressions of pain sensations and meaning based on our past experiences. So everything is framed according to what we've already gone through and lived through in our lives. That's why pain is not the same for each and every person. In this next section, we are going to look at some of the literature and what it says about pain and how pain can affect different movement patterns.